Good afternoon, everyone, and welcome back to the Dean's Leaders in Lagniappe lecture series, where we welcome public health leaders to share their innovations, ideas, and leadership values that got them to where they are today. I'm Thomas LaVeist, Dean of the Celia Scott Weatherhead School of Public Health and Tropical Medicine at Tulane University. As we get started, I want to briefly ground us in the work that we're here to address and the land that we inhabit. The city of New Orleans serves as a continuation of a great indigenous trade hub known to the Choctaw, Homa, Chittamauga, Biloxi, and other native peoples as Balbacha, or the land of other tongues. For thousands of years, people have lived along the Mississippi River, and our city served as a place for diverse cultures to come together. New Orleans today is situated in the American South, historically and presently the epicenter for inequities in our nation. If we are to make our world a more equitable one, we must include and center the places and communities subjected to the largest inequalities, in part because the solutions we seek live in those exact communities. The origins of this lecture series come from a school-wide desire to give our students the tools and experiences needed to become the next wave of innovative leaders. Through those opportunities to meet and learn from some of the most distinguished leaders in public health, we aim to build a bridge between our future leaders and our current ones. This lecture series also boasts something distinctly New Orleanian, Lagniappe. Lagniappe is a concept you'll find throughout southern Louisiana and is the idea of adding a little something extra or unexpected to an occasion. We've adopted this concept of Lagniappe by incorporating the arts into this public health lecture series. Our next exhibit in the Quiet Drift is going up now in the DeBall Gallery and will open tomorrow with a reception from 5 to 7. We hope that you can all attend. Now let me introduce this month's speakers. Dr. Perry Halkitis is currently Dean Hunterdon Professor in Public Health and Health Equity and Distinguished Professor of Biostatistics and Epidemiology at the Rutgers University School of Public Health. Dr. Halkitis is an infectious disease epidemiologist, applied statistician, and public health psychologist. He conducts this work through his research, teaching, advocacy, and activism. Also joining us today is a New Orleans neighbor, Dean Edward Trapido from LSU School of Public Health. Dr. Trapido holds the Wendell Gunther Professorship of Cancer Epidemiology and is Deputy Director for the Population Sciences in the Stanley S. Scott Cancer Center. Much of Dr. Trapido's career has focused on inequities in health and diseases in different populations. Thank you both for being here today. And Ed, you're first.
Good afternoon, everybody. Thank you for joining us today. Just to follow up, and thank you, Dean LaVeist. Just to follow up on your comments, the original name, the Native American name for this city was Bulbancha, and it was a thriving Native American and African American community before it was invaded by Europeans. If you ever get a chance, go to the NPR story about the history of the area. It's absolutely fascinating. So I will talk to you just for a little bit about my experience. These were the things I was asked to comment on: philosophy of good leadership, values, and advice. Let's see if we can get this. Here we go. Actually, this is a sculpture in a garden in Lyon, France. I'm always, doesn't really say leadership experience on the sphere, nor does it have that green line, which I couldn't get out. But I'm always amazed by this. I'm always moved by this particular sculpture. So I've been in a bunch of places. I actually, not that many considering it's my whole career, but I spent a fair amount of time at the University of Miami in their Department of Epidemiology and Public Health. They have a program, not a school, of public health. And, I moved up in the ranks while I was there, started their PhD program. um, and was also active in their cancer center. And I had a variety of titles. And that just happened over the course of time, sometimes because I was the right person, sometimes because I was the only person. So leadership can happen in a variety of ways. I would like to say it's always planned. That's not the case. Um, Sometimes opportunities come which you take advantage of if you're fortunate enough to be offered them. Then I spent a lot of time at the National Cancer Institute. And in the last, I've been there twice. In the last iteration, I was the associate director for the epidemiology and genetics, now called genomics research program, which is actually the largest funder of epidemiology research in the world. I had a portfolio of worth $250 million of 350 grants. And people were very kind to me at that point because they thought I actually controlled those dollars. And I was treated royally. Of course, the minute I stepped out of that position, I went back to being like everybody else. It was an interesting time, not probably as interesting as it's going to be, but it was an interesting time. It was during one of the Bush administrations, and one day I got a call from the White House saying I needed to defund a program on screening for cervical cancer because it involved a virus, which we now know is a human papillomavirus. I said, let me consider your request. And then I went to speak to my boss. And the way it works is the head of NCI is a direct appointment of the president. There are only two direct appointments for the president from NIH, the director of NIH and the director of NCI. Everything else goes through a slightly different process. The individual institutes are not presidential appointments. But anyway, so the head of NCI was the boss of my boss. So I was 3 levels down. And they said, well, you know, we have to respond to the White House. And I called the White House and said, I'm sorry, I can't defund this program. This has been through peer review. This has been through council. And I have no justification to do it based on the science and based on what was approved. If we defund this, the entire peer review system is a sham. And I figured, you know what, if they want to fire me, they'll fire me. They didn't. They did go around me, and they made, and I had warned the PI about this. She was at the Moffitt Cancer Center. I warned her, you might get a call from the White House about this. And, but they worked out an arrangement where she could keep the funding as long as she made some structural changes in what they were telling the population. So sometimes leadership puts you into interesting positions, and you always have that choice. Do I take the position which I truly believe is the right position, or do I think about what the implications are for me personally? And it's not an easy situation, and it depends where you are in your own journey. And there isn't a magic answer. I would love to say principles always rule, but that's not really the case. Principles rule when you think you've really got a strong case to be made and you're comfortable standing up for those principles. Some of the other time you just have to swallow it and go with it, unfortunately. But that's part of leadership too. It's knowing when to take the high ground and when to say, this one's not worth it. And then I came here. Now, it sounds like I just went to 2 other places, but I actually went back and forth twice to each place. So But I came here 15 years ago. I came here as the Associate Dean for Research for the school. And 2 years ago, I was made the interim dean, and last year, the dean of the School of Public Health, about 6 blocks from here. And I also have a role in the Cancer Center, as was pointed out. And I'm happy to do that because cancer is a big issue in the state, and I'm leading the population studies program part of it. And I think it's an important place to be working. It involves research, community engagement, and the Cancer Center membership is open for everybody from Tulane if you're interested. So by all means, follow up on that if you're interested. And several members of the School of Public Health are members of the Cancer Center. I also worked some time for the International Atomic Energy Agency. So in case you're not aware of it, the IAEA is a sister agency to the World Health Organization. They're both part of the UN system. The International Atomic Energy Agency works to find peaceful uses of atomic energy. They do go and check for weapons in other countries, so that's where you've heard about them, checking for nuclear bombs and nuclear arms. But they also realize that radiation can have an important role in preventing or curing cancer. Something like 90% of cancer can either be cured or palliated by radiation therapy. But if you're in a country where you have an irregular supply of electricity, you can't run radiation therapy equipment. But they also use radiation for treating microbes in water and in soil. So they do a lot of food programs. So they are doing a lot of public health, even though they're the they're used to be called the Atoms for Peace Agency. And then in the community or in professional organizations, I've also had leadership roles. So I've been on the chair of the board of trustees for Crescent Care. Most of you have heard of Crescent Care. It's one of our best FQHCs. No Age, which is the New Orleans Advocates for GLBT elders, and I'm the secretary of that board. I've been president of the American College of Epidemiology and founding president of the Epidemiology Foundation. So leadership happens in a variety of places if you're open to it. It just depends where you are in your life. And it's more than where you are in your career, where you are in your life and what time you want to give. But people in public health make wonderful members of boards because they are looking out for the population and not for the profit. And so that's really nice. Whoops, I think I skipped one, the values. This is also a sculpture in France. This is actually in a shopping mall. So values, honesty, integrity, transparency, communication, inclusiveness. It's hard to argue with any of these. These are good things to have, but I think it's hard to talk about yourself, but I mean, I do think that I keep this. The other thing is trying not to take myself too seriously. Nobody wants a dean who is 100% serious all the time, and more than that, is always impressed with himself or herself. And the one thing about being a leader is you've had a chance to make all those mistakes so far, and hopefully you've learned from them. But there are always new ones I can make, so it's a possibility. So philosophy, know where we're going, know how we're going to get there, and who we're going to take along. So when I became dean, I said, we've got to build the school. We've got to strengthen areas that are weak. We've got to make sure that we're providing our students with the skills they will need in this era. And if we're not doing that, and we're working on an old model, we're not going to do a good job. Leadership is remaining connected to the community, certainly, and to involve other people in the decision making, and to empower people so that the best thing I think a leader can do is empower people so they become leaders. Not everybody's going to be a leader, but you can always be a leader in what you do. And the other thing I learned from my first boss in Miami, um, everything is an opportunity. You have the option of taking it or not, but always look at the bright side of when somebody says, what about this? What about that? What about that? I think of these as opportunities. Now, you can't do them all, but you can do, you can pick and choose the ones that you think will be most meaningful. And then finally, my advice. And my advice comes from a couple of people. The first one is from a gentleman who had retired from NCI, and I knew him when he was in Miami. He said, as you go up the ladder of success, be kind to the people you pass because you're going to see them on the way down. And I have experienced that, and there's a lot of truth in it. The second one, an administrator at the NCI told me I was having a problem with something. She said, is this the mountain you want to die on? Meaning, is this the fight that you think is worth having? Or is it a small thing that basically you're going to forget about in 2 weeks? And I've tried to follow that. Not everything is worth fighting for, but there are a bunch that you do have to stand up for. And then the only other thing is I can say is you can't, although some people know, and we hired a faculty member this year who said her ambition is to be the dean. And she has no experience other than she just finished graduate school. There's nothing wrong with saying that, but that's not, it's hard to plan those kinds of things. My career has been, I always think of this in my mind, there's an image of water going down the mountain and it hits a rock and it has to go a little bit differently, and it hits a branch, it has to go a little bit differently. You still get to the same place, but it's not planned. And I feel like you or I have taken the route that was partially decided by me, and a lot was decided by what the opportunities were, where I was, and what I could make out of it. And that's how I got to be where I am. And thank you for letting me talk. And I appreciate this. Thank you.
Awesome. I just need to get something out of here. And I'm really happy to follow my friend Ed, because I think that when I think about my career also and what's happened over the course of the last, I don't know, few decades, it's never been a straight path to where I am today. So if you asked 18-year-old Perry where he would be at almost 62-year-old Perry next month, Pisces, sun and moon, he wouldn't be thinking this at all. I was born a child of Greek immigrants, had a limited education. My choices in my life were to go to school and to be a medical doctor. I knew I didn't want to be a medical doctor. I somehow found myself eventually finishing my undergraduate degree at Columbia, ended up teaching school and recognizing that really I wanted to be a scientist. Ended up getting a doctoral degree in applied statistics and was a psychometrician and a statistician for a very long time in the late 80s and early 1990s. But at the same time, my world was falling apart. The AIDS epidemic was killing all of my friends. And so my life by day as a suit doing statistics was very different from my life at night as an activist and part of ACT UP. And somehow those two pieces needed to be fused together in a meaningful way. And so I did what you're not supposed to do in 1996, which is give up this really great career that I had and switch gears, and ended up being the director of research at Gay Men's Health Crisis for 2 years. And that was, a big transition, but the right transition, because it felt like my identities were coming together at that point in my life. I stayed there for a couple of years, ended up being recruited by NYU eventually, stayed there for some 20 years building programs in applied psychology and in public health. And, in these roles, right, that came to me, like my third year there at the university, I was asked to be, without tenure, the chair of the applied psychology department. I don't know. I just did it. And then I found myself being an associate dean. And then I found myself building a school of public health. And then eventually in 2007, found myself going to Rutgers and doing, as I said to the students earlier, and I think to my other colleagues, doing the things that New Yorkers are not supposed to do, go to across the Hudson River to New Jersey. But I did do that. And it was the best decision I've made. And I've been there for the last 8 years trying to help to build what I think is a modern school of public health in New Jersey, very much like your dean is doing here, like with a very modern approach to what public health needs to be. So I often, when I'm asked to describe my career trajectory, I always say it was never a straight path. If you asked me at 18 if I wanted to be a dean of a school of public health, I wouldn't even know what that was. I wanted to be a rock star and a supermodel, but that didn't work out for me so well. So who knows? But every opportunity that came along, I didn't take it, but I certainly looked at the opportunities. And so where the road would take me. So the path to where I am today, I describe it like the Greek metro station in Greece, the Greek subway. In Greece, when they were building the subway for the Olympics in 2004, they were expanding the subway. One of the laws required that when they found architectural elements of importance, they couldn't drive right through them, right? They had to work around, they had to study them and they had to work around them. So if you get on the metro in Athens, it often goes like this, right? But eventually you get where you need to be. And by the way, the journey is much more interesting along the way because you get to see all these beautiful things. So that's my big takeaway to you. Enjoy the journey there. So I'm going to not, so that's just enough about me. That's all you need to know. But I thought what I'd do today is give you some ideas about where I think public health is and what are the things that we all should be thinking about collectively at our schools, in our departments of health, in our educational programs, in our research programs, in our community engagement programs. So I'm going to describe these things to you, these opportunities and challenges that I'm going to and then I'm going to preview some of my ideas and thinking in this book that's about to come out. But I'm going to frame these ideas to you as opportunities, because I believe very strongly that something that's a challenge is also an opportunity. And there's always this tension that exists. And somehow, if you can balance that tension, right? So Piaget talks about disequilibrium, right? And how do you manage the disequilibrium to learn? Well, you take the extremes and you find the tension and you find the sweet spot between them, right? So my whole life, I've started to think this way. My whole life, I've tried to move away from this idea that there's these dichotomies. There's right and there's wrong. There's black and there's white. But somehow there's this gray area where we all coexist. And boy, we better find that gray area for the next 4 years, because it's going to be totally, totally tough. But these are the tensions that I see, and I'll give you some initial thoughts on them. And then, maybe in our conversation, we could talk about them a little bit more. So there are a bunch of conditions that are going to affect our work in public health, that have been affecting our work in public health for the last few decades, and certainly for the last decade. And the first is the attack on public health. The attack on public health is obvious, it is real, we experience it every single day, and it makes our lives difficult. And we could retreat and say, well, they hate us and we can't do any more good. Or we can take it as an opportunity to say how we do business and how we interact with the public must change. Because the attacks are not without context and not without merit. We have not done everything perfectly in the field. So this is a little bit of a wake-up call for us. A little extreme, but still a little bit of a wake-up call for us. Number two. As a discipline, we very much started decades and decades ago as a multidisciplinary discipline, where psychologists and social workers and nurses and physicians and OTs and PTs came together. And that's what I think what drew me to public health originally, this idea that there are multiple disciplines coming to this space and talking about the same thing from a slightly different perspective. It's kind of what I think makes my work, why I love my work so much, is because I have this frame as a psychologist, right? But I also have this frame as a public health person. an epidemiologist. And somehow I've got to reconcile the population and the person to find the sweet spot to do the work that I want to do. I think we've lost this. I think that we've become a little over-specialized in public health. I think that we need to be much more expansive. I have been very, very deliberate in my efforts as a leader to try to recruit at the Rutgers School of Public Health people from various professions, people who have not been in academia before, so that public health actually finds in our school the roots in which it originated. Number three, one of the challenges I think we have in working with the public is working towards a unified goal. And I said earlier to some of my colleagues that, you know, I think the problem that happened during COVID was that all of a sudden people were coming and knocking on your door and talking to you on TV and telling you had to be vaccinated. And why would you believe these people? Who are these people? Right? And that the people who ended up being able to change were the people who trusted us. But I don't think that we, in our professions, in our teaching, in our education, in our practice, have been as deliberate as we could be in creating a unified voice with the public. And so this is a moment where I've asked my colleagues in New Jersey to think about, it's a sort of a quiet moment, right? We still have COVID for sure. We still have HIV for sure. We have all of these problems that exist. But being embedded with the populations that we serve, not just during our 180 hours of practice, but as much as possible, and creating a unified voice, a unified goal, which is ultimately uplifting the health of all people, has to be our way moving forward. And I think the separation that's existed, not only between public health and the public, but also higher education and the public, has been at our cost, as a cost to us. And so it's a chance and opportunity to look back. Number four, and I think that under the Affordable Care Act, this was the direction that we were moving in, which is advantaging prevention, health, and wellness. Looking at public health as ultimately the approach to well-being that is the one that's going to be the best for the population, that's going to be the most cost-effective, that's going to save the most lives. You ask the general public what health is, and they say doctor, and they say illness, and they say treatment. They don't think prevention. What are we doing in public health? It's an opportunity for us to demonstrate to the public that what we do also enhances the health and well-being of people. Seamless data sharing. I'm having this conversation endlessly right now. I'm on a National Academies panel right now, and we're talking about why is it that we can't create a place where people can have all of their medical records and their vaccines and everything connected to each other. The FDA has moved in that direction. I think that what we also need to think about is connecting public health data, prevention data, to health outcome data in a more effective way, if we're going to have an effect on the health of the population. One of my pet peeves, and Tom will know this, is this idea of population health versus public health. If you read any of my work, you will have read this sentence: population health, meaning public health for doctors. I think that as a discipline, we have done a very bad job at owning what we do and putting our place at making sure we are at the table with our colleagues who are physicians, rather than allowing individuals who are in the medical profession, who I love my medical provider friends and colleagues, but allowing them to try to think that they need to do public health instead of us. The example of why this works so bad is seen in New York City. New York City has perhaps one of the best Department of Health in the world. And during the COVID outbreak, the decision was made to pass on the responsibility for contact tracing and ultimately for the vaccination to the department, to the Hospital and Health Services Corporation instead of the Department of Health. Why? It didn't work out so well for the city of New York. Okay. Part of that requires that we continue to be active in our efforts to address disease, not purely from a biomedical perspective. I have said, I don't know, maybe 50,000 times, I don't know, maybe not that much in my life. People don't want to get COVID. People don't want to get cancer. People don't want to be obese. People don't want to have a meth addiction. People don't want these diseases. They don't want these health states. People don't want to have depression. People don't want to have anxiety. But life circumstances and biological circumstances and social circumstances place people in these conditions. And very often we treat the individual as a vessel for a pathogen, as a vessel for the disease, rather than as a person. And so I think it is incumbent upon public health to continue to try to advance a model that was put forward in 1977 by George Engel that talks very clearly and very succinctly about the interaction of the biological, the social, and the structural. And I think just waking up and assuming that just because a vaccine is available, people are going to run out to take it is really short-sighted, because it pays no attention to people's lives. And so I have spent a good part of my career talking about that, and that's a psychologist in me speaking. Number 8, this is obvious now, but it wasn't so obvious when I gave it at a graduation speech about 7 years ago. We can't have politics be separate from public health because politics is shaping public health. And so we have a responsibility in our field to be engaged in political discussions. We have a responsibility to be training students to think about political careers. Unless we have people who understand public health making the decisions about public health will continue to be chipped away. It will become medicine, it will become biomedical, and prevention as a tool to keep our country healthy will slowly but surely disappear. I'm not trying to be alarmist, I'm just telling you what I think you already know. Hate. When I was ASPPH chair, boy, I thought that year was exhausting, Tom, actually, because it felt like I had like a 5th job. But when that year went, before I preceded your wonderful dean as chair of ASPPH, my initiative was around hate. And I can talk about social determinants and structural determinants and commercial determinants and all of those things. But I ultimately think that many of those things are rooted in hate and dislike of the other. And so let's just own it and say it. Right? And it's not that difficult to say that in our society, there are segments of the population who hate others. And because they hate others, they deny them rights. And because they deny them rights, their health suffers, whether you're a migrant or a trans person or a woman or any other group that's put upon. So calling out hate as a driver of disease is to me, something that I'm going to live by to the day that I die. Number 10, I love teaching about theory of reasoned action and theory of planned behavior and all that stuff, but people don't act that way. I remember being a very, very young baby researcher in 1998, and we had one of the first funded grants on HIV prevention that was targeting gay men, because you could all of a sudden talk about prevention for gay men because meds were available after 1996. So you could start telling gay men who are HIV positive to maybe think about their behavior, right? Because the people weren't all dying, right? And I remember going to a meeting as the young, naive little researcher that I was, and having people say, well, you know, Halkitis, if we increase their self-efficacy, they will use a condom every time. I'm like, not 5 tequila shots in, they're not going to use it. And so these models that we've been using in public health and in health psychology and in medicine often, too often, depend on the idea that human beings are rational operators, that information in and of itself is going to get people to change their behaviors. When we know that while rationality and cognition certainly plays a role, it is often usurped by other things like beliefs and emotions and some good things like empathy, which we should take advantage of much more. And this one, it's not 111, it should be 11. I am so happy when Tom talked about this. We also have been doing this connection between art and public health. When I did my first class that I taught HIV, I took my first HIV prevention class that I taught, some 25 years ago. One of the things that I had my students do was read plays from the early days of AIDS. And why did I do that? rather than diving right into the MMWR. They read that too, eventually, but because I wanted them to live in that space. I wanted them to see what it felt like emotionally to be in that space. And I am a true believer, I am a firm believer that art often is way ahead of science. And I think that we have to advantage art much more. This is art, an art installation in a hospital in Brooklyn that was done by Keith Haring, who was, a very famous artist when he himself died of AIDS. And the messages that we're getting across about HIV were much more powerful. As a young gay man in my 20s in the 1980s, I can tell you that scientists were somewhat talking about it, but really the public and the artists and the musicians and the playwrights were talking about it a lot more. And so let's work with them and take a lead from them in helping to advance things. So at the end of the day, here's what we all want, I think, right? We want to get to a place where there's health justice, right? We've been talking about health disparities, blah, 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 blah. Yes, if I read another paper that tells me that there's differences between groups, I'm going to just like poke my eyes out because I'm Greek and I'm like, that's what we do in our tragedies, right? But also, ultimately, yes, it has to be about health equity, but it has to be about health justice. So I am imploring all of us to continue to do work that is less about documenting difference and more about challenging the difference in the outcomes. Because we can continue to document differences in health till we're blue in the face, but it's going to do us no good as a society. One of the pleasures I've had at working on these ideas are encapsulated really well in this schematic picture here that I worked on with my friend Leslie Cantor, like really thinking about how it is that we bring together clinical care and public health. And, recognizing that in order to do that, yes, we have to work with the community. Yes, we have to work with academic health centers. Yes, we have to work with the government, but we also have to work with business and industry, right? Business and industry know how to advance technological elements and other aspects of that move product. And so when the COVID vaccine website crashed 5 minutes after it first came up in New York City, I first said they probably should have hired a 12-year-old instead of a 60-year-old to design it. But okay, forget that. Why didn't we work with the business industry? Why don't we work with industries to create those? Why are we trying to create things from scratch when we're not really equipped to do that? They're not the enemy. Clearly, the administration that's about to take control on Monday recognizes that. I think we can advantage ourselves also from aligning ourselves with the business sector. So I had an opportunity over the course of the last year to work on this book, which I think right now is called, as of this moment, Public Health Unmasked: How People and Politics Shape HIV, COVID-19, and Other Modern Day Pandemics. And if you'll indulge me for just 2 more minutes, I want to just read you 2 paragraphs from the forward of the book. And this is the first audience I'm reading it to ever. Is that okay? Can I do that? Okay, cool. Awesome. I have to open my laptop to do that and then put my glasses on. And then I promise you I will stop and we can get back to our conversation. It is right here. No, it's not this. It is right here. Here it is. It says, this is from the forward, we too often overlook how the behavior of people catalyzes pathogen spread, leading to outbreaks and pandemics. What we need is a shift in paradigm to a person-centered approach, an approach in which public health works closely with people, understands people, recognizes their cognitions and beliefs, works with their belief system to leverage their emotional lives and empathy, and advantages health interventions, rather than assuming that human beings are rational operators who make decisions that benefit themselves and society at large. We know all too well that this is not the case. Humans are not rational operators, and so our training of public health workers must equip them with the skills to understand the complexity of human beings. Putting people at the center of intervention design necessitates such undertakings. Throughout the course of this volume, I delineate how emotions, empathy, cognitions, and political learnings impact health both in positive and negative ways. In turn, I discuss how we must address these contracts in our public health approaches to infectious as well as chronic disease. Addressing these challenges also requires a paradigm shift in what we teach, how we teach, and how we engage with our students, to develop an ethos to always keep the public in public health. And in doing so, the public health leaders of this future must sit alongside clinicians, including medical professionals, during such outbreaks. We in public health must be the ones to emphasize people holistically when our clinical colleagues are not. Unless we prepare the next generation of public health leaders to be able to speak, to understand, and work with populations that they serve using a person-centered design, when the next pathogen surfaces, our focus will once again be on biology rather than on humanity. And so that's kind of what I believe. Book will be out at some point. Maybe it'll have a different title, like Perry's book or something like that. All right. Finally, I'm going to leave you with this. If you feel energized to do something, there's a group of us that have gathered creating a group called Defend Public Health. I have the great fortune of being on the coordinating committee, my friend Gren Gonzalez from Yale and others. And we are, you may have seen in the New York Times and in The Hill an article where our letter about RFK was recently published. We are always looking for people who are interested. We have thousands, but students, faculty, practitioners to join us in our efforts. So there it is. There's a QR code that I made. It may not work because I made it. And, you know, it does? Yay, good for me. Good for the old guy. Yay, awesome. So, so there it is. Use the QR code. Join us in this conversation. And if you're interested in learning more, here's my website, here's my email, and here's our X account at the school. Thank you very much.
Hey, that's a really interesting story you told about your experience when you was at NCI and got that call from the White House. Can you say a little bit more about that? What was the thought process? What did you do? Did you seek advice from others? How did you go about making that determination that this was the best way to handle that situation?
My initial response, of course, was a little bit of surprise since I don't normally get a call from the White House. I thought, let me talk with some other folks that I work with and see how they would handle it. And then I went to my boss, who was head of our division, and said, how would you handle it? And he said, well, you know, we have to be responsive to what the White House wants. We're an executive agency. And so I thought about it, and I called the PI, and I said, this is what's happening. I want to let you in because it's going to be, it will become public. And I said, please tell me what the issues are that you're aware of, and let me tell you what the complaints have been. And she told me, and she said, this is ridiculous. I mean, it makes absolutely no sense. And I said, well, not only do I believe you, but I'm going to take the stance that we have a very important process that all universities and the NIH adhere to, which is peer review. And that what they're saying is peer review doesn't matter. It's going to be a political decision. And I thought, I can stop it, which is as far as I can go, and say, no, we're not going to do this. And I told my boss I was going to do it, and he said, well, it's your call. So I went ahead and I told them, as I mentioned. And the next thing that happened was the White House got in touch with the director of the NIH and said, we have a problem we have to resolve. And they put someone on the case to just speak with the PI, and they made an arrangement. So it turned out it did not originate in the White House. There were two state representatives from Florida who made a complaint to the governor, who then called the White House. So they didn't have a vested interest other than satisfying these two people. And so they came around to, we can come up with a better solution. And I felt, look, I have to support the peer review. That's why I'm at the NIH. And so that's what happened.
Yeah, but I still think it was remarkable that you were in a, you know, must have been a very uncomfortable situation to be in, critically important, where you basically had the opportunity to either defend a cherished principle of science and
Right.
academia, or not. And many people would have folded under that pressure, I think.
To me, there was never any doubt in my mind that that was the right thing to do.
Mm.
I, I, I was a little bit worried about what implications it would have, but not sufficiently
Mm.
to say, I'm going to just allow them to do this because, you know, it happens once and then forever that becomes the easy path. Just make a complaint from the White House and things. Now, I don't know if that would fly in the next administration, but in that administration, it did. So, and I called the PI back and I told her what my decision was, and I didn't know what was going to happen next.
So to bring Perry's comments, and this was a hill you were willing to die on. You were willing to die on the hill. So how do you decide which hill to die on, which one not to? I mean, this is a question I think that everyone in public health is going to need to face time to time over the next few years. You know, if things play out the way the next administration is planning, you know, there'll be challenges to what we do in public health, and we'll have to make some decisions. How do you decide which hill to die on?
He asked you first.
You asked me first?
Well, you mentioned the hill. you
Yeah, I
mentioned
mean,
dying on
I'm willing to
hills.
die on every hill. I mean, I think that, you know, I'll talk about it from my role. I don't know if I can address it from the perspective of politics, because, you know, as you know, I was an ACT UP guy. I tied myself down on Wall Street. I didn't care, right? I didn't care what was going to happen. But I will tell you about my role as a dean, how I do those. And there are decisions that you have to make, and there are lots of decisions, and some of them have a much bigger impact on the well-being of the organization you're seeing, and some just seem like small. And I think that I am unwilling to die on the small things, right? This, like, you know, like, let me give you an extreme example. Making sure that, you know, the syllabi are all consistent and where the competencies are listed seems like a war I should not be taking up with my faculty, right? You know what I'm talking about, right?
Yeah,
However,
a war that we are literally going through
we
right
are
now.
going, but we're going through
Literally
it too.
right now.
But making sure that that all of my faculty have the tools and the skills to teach, recognizing that one assessment in and of itself cannot be part of the syllabus, but have to be multiple forms of assessment in every course, is something I'm willing to die for. So I weigh it. Right? I weigh, like, you know, what if I thought every single thing, then when I use my voice, ultimately for something that really I think hugely matters, it's not going to matter.
Yeah.
I can't talk about the political thing because I don't know what's happening on Monday.
Well, no, I don't really want to talk about the next administration. I'm just saying, as a field, as you point out in your comments, that the field is under challenge. So you and I met much more recently, although we covered similar ground
Mhm.
back in the 80s with the whole HIV thing. I we didn't meet at that time, but I admired greatly what you guys were doing with ACT UP. I was very much admired the work that you guys did and thought that you had was very, very impactful, and it was exactly what was needed at that point and at that moment. And I think you were very, very effective with that. But I do want to get you to talk a little bit more about politics from the standpoint of something you said in your speech. So during the COVID pandemic, I had the fortune or misfortune, I'm still not sure which, to serve as the chair of the governor's task force on COVID. And we were very engaged with the national administration that was working on creating the new vaccine. And I got to meet with the Operation Warp Speed people. By the way, my first comment to them was, who had the dumb idea of calling it Operation Warp Speed? It was about the worst thing I could think of to call it, you know. But one of the challenges that we face, another comment I made in that meeting was, I see a committee full of virologists and vaccine developers.
Mhm.
And therefore, I see a committee that is totally inadequate to address this problem, because creating a vaccine will do nothing for COVID. Getting the vaccination is what's going to do something for COVID.
Right.
And I don't see the expertise to get the needles and arms at the table. I see the expertise to create a vaccine at the table. You talked about the importance of upgrading our model for behavioral change and to recognize that humans are not always rational actors. And I can assure you from some of the conversations I had during the COVID pandemic, humans are not always rational actors. You're absolutely correct about that. How do we upgrade our models? How do we engage with human behavior?
Yeah. So first of all, I want to say about the ACT UP thing. As you might tell, like I find like strengths and problems and everything, right? The ACT UP thing was really good, and we did really great work. We didn't do some great work, which was like we forgot communities of color were being affected, and we didn't invite them to the table with our activist strategies. And I don't care who those other ACT UP people say, they were not at the table, and we fell short, and we should own that. Okay, so how do we change it? Well, we start with a recognition that people's belief systems start to develop from the time that they're zero, right? That people become vaccine deniers or become skeptics of science, not overnight, but over the course of their life trajectory from their families. So I think what we need to do to upgrade our models is really try to figure out a way that taps into people's belief systems, how they are, how they got there, and then intervene on those elements. Because otherwise, if we're just giving information, we're band-aiding it. What I'm saying is that there's a deep-rooted, a much more deep-rooted psychological driver that's causing people to make decisions about their health, right? And we need to understand what it is in their lives that caused them to get there. Why is it that the racist, for example, is a racist, right? What is it in their life experience that gets there, and try to tackle that experience to try to deal with their racism? And it's not an easy task that I'm putting forward, because it's not like a 5-minute intervention.
It's also extremely individualized and extremely nuanced.
Correct.
So how do you do that at a population level?
You do it at a population level because there are clusters of people who act the same way. And they're probably the belief systems that get people to be vaccine deniers have some common elements. And then you group the people around that. Just like you group the people around vaccine hesitancy. When I would do interviews during the COVID pandemic, and then people would ask me what COVID vaccine hesitancy is, I would say, well, which population are we talking about? So it's not an individual thing. It's probably more of a clustered approach to that. Because a group of people, and I was talking about this with the students earlier. One of the books that I found inspiration from in the last few years is something called The Status Game. And I think we may have talked about this. And The Status Game is a book written by Will Storr, who's a journalist, who is also a sociologist. And he talks about human beings as all other animals, and that human beings are always trying to establish their status in the world, right? So one of the things I'm always challenged is when I think about the people that I grew up with, right? Why are these people who were born of immigrants so intent on denying rights to others who are coming into the country right now, right? And what Will Storr would say is that they have gone a little bit up in their status, but not far enough in their status to be secure, so that they need to keep it below. So keep the people below them in their place. And so what I think we have to understand is what these insecurities that people have, these beliefs that people have, that drive them to make decision making. And I think that is also part of what is driving people's health decision making also.
Okay, we're really low on time. I want to open it up for the audience. If anyone's got any questions, please raise your hand.
There's a hand.
Hi, my name is Jared Christian. I am a second year MPH disaster management student. This is more of a policy question, and I am not a policy student, so just be prepared. I'd say as someone who's coming up as a Gen Zer, I feel like when I'm in classes, a lot of times we talk about how research should drive policy decisions. But in my opinion, from what I've seen recently, I feel like policy has a bigger impact on research and what we're allowed to do, especially in practice, and how we're allowed to look at the environment and look at these different things. And so how can we combat that kind of shift towards policy driving research rather than the other way around?
Take that one.
That's a very good question. Thank you for asking it. I have to figure out an answer. It's still, so my approach is twofold. One is providing information to policymakers is still very important. And if it's not the policymaker, him or herself, it's the people around that person, because they can influence what that policymaker decides. The other thing is people remember individual stories.
Mhm.
And so if you can relate, you know, I give an example in one of the courses that I teach about a woman who keeps going into her doctor and she has a cough. The doctor treats her. Um, she goes back, doesn't do any better, has another medication, so forth. Finally, the nurse says, well, where do you live? And can I come visit? So the nurse ends up going into, I'm making this short, goes into the house and notices that there's mold all up and down the walls. So telling the story about how the background information, the place somebody lives, determines a lot about somebody's health. Talking about the need to change the environment, that kind of story, especially if you embellish it, has more power than telling this legislator about the numbers behind it. And so I think it's a combination approach. And it's just like the two of us went to Capitol Hill last year and spoke with some of our representatives and one of our senators. And I was fortunate enough to take a student with me. That student got more respect from the senator, frankly, than I thought I got. And that was great because that student represented how she is impacted by public health. I think stories can help where data doesn't sometimes help.
I mean, I have to agree with the story thing, and I think politicians use it badly. So if you watch the State of the Union every year, there's always somebody with one person as an example of one story. It's sort of like kind of using it. I think you have to keep telling the story over and over again for lots of different people. The story that I kept telling over and over again when people complaining about masks and about vaccination, and every time I did an interview with the press, I would say, my brother has MS. He's 3 years younger than me. He's highly vulnerable to COVID-19. I don't want my baby brother to die. I wear a mask and I get a vaccine because of him. And when you think things like that, people are able to, I think it's exactly what it's saying. It's like you bring it home for them. They have to think about, they have to put somebody that they love, somebody that they care about at their center, right? We can't just expect our society to stop being selfish, but we can certainly find the person that people care about in their lives and center the decision-making around those who are most vulnerable, because everybody has them.
And I think that communications is one of the things that we do so poorly.
Poorly.
Public health. It's horrific. And I think a lot of what went wrong during the pandemic was about bad communications. I mean, things like Operation Warp Speed, social distance, which is
The
which is
words
the
were all wrong.
we don't want people to be socially distant. We want them to be physically distant. Why would we call it social distance? It is the craziest thing.
Well, Tom, it's because we weren't at the table, right? When you turn on CNN or MSNBC or whatever the other channels are, you know, the public health people weren't being interviewed. It was MDs being interviewed, which was, I thought, like, that's an interesting. And the other thing we failed to do, I'm on this National Academies panel right now that's looking at the messaging around COVID-19. Well, not only do we have to be proactive in getting the messages out in effective ways, like you're saying, but also dealing with the ineffective messages that Nicki Minaj and other people are putting out there, because those are doing much more damage.
Joe Rogan.
Yeah, I know. So we have to teach. I think we have an obligation to teach our students to be able to communicate with people in everyday lives in real ways that, you know, we're not doing a good job. We're just not.
I don't know that we know how to do it.
But communications people do.
Yeah, I assume.
Hi, I'm Kelly, PhD student, also former journalist for Network News. And I went to a friend's house the other day to visit with her and her kids, and her mom was there. And her mom was a very big anti-vaxxer vaxxer. She lives in rural Texas. And she was reflecting on the pandemic, and she made comments like about her grandchild. She said, I had to go get the jab in order to come see my grandchild. And, you know, that's appealing to her, someone that she cares about. But again, I think her identity is more strongly tied to her politics and her kind of anti-vaxxer stance than it even is to the love of her grandchild. She did go get the jab to go see her grandchild. It's just how do you even tackle this? I mean, that's again assuming humans are acting rationally.
I mean, I think again, we come back to the idea of the stories. I think this is another story you're telling right now, right? We can see that her decision making is based on her politics, or we can see the other side of it, which is like she ended up getting the vaccine, right? And use that as an example to model for other people. She cared about her grandchild enough to do that. I think those are the stories we need to build on.
I think we have time for one. I'm looking for an indication. How are we on time? We're over.
Oh, I'm
We're
sorry.
over. All right, let's
Thank you.
let's do parting shots. Anyone have any closing remarks that you'd like to make?
So we need you to become leaders. Public health desperately needs new leaders coming up. And there are, you know, this era we will get through, and we need people who are well-trained and activists who can really pave the way and become leaders in your communities. And in the meantime, work with communities and become active where you can. It's really important. You can leave there, even if we can't make a difference nationally, we can make a difference locally, and that's a place to start. Stay engaged.
And I would say disrupt. And I would say disrupt to the outside forces, but also disrupt within public health. Where you think public health is being lax and is falling back on what it's accomplished in the past and is not willing to advance and is not willing to change, you need to push back there. I think there's a way to be disruptive and ethical at the same time.
Big thank you to everyone for joining us today, both online and in the auditorium. And big thank you to our speakers. A quick note announcement before we depart. We hope you'll mark your calendars for the next Dean's Leaders in Lagniappe lecture on Wednesday, March 12th. We'll be joined by Dean Sean Gibbs of Texas A&M University School of Public Health and Dean Tara Sabu Atwood of the University of South Carolina Arnold School of Public Health. I also encourage folks to join us for the opening reception for our new art exhibit in the Quiet Drift, which will be opening tomorrow night here under the Ball Gallery. Some of the artwork is already up. Please go in and enjoy it. We're excited to present this year's series of arts and public health programming thanks to the generous support from the DeBall Foundation. We hope you'll enjoy this exhibit, which will be showing in the DeBall Gallery starting March 6th. Thank you all and have a great week.